Chronic Kidney Disease Risk Study using VMT and TDA models of 4 key inputs: pp, MAP, FPG, and VF%, number 1418, VMT sharp 742, TDA sharp 025, November 3, 2025. Gerald C. EclaireMD Foundation. Category: Nephrology. Preface. Over the past 16 years, I have continuously refined my mathematical physical modeling approach to human health through the GH method, Viscoplastic Medicine Theory, VMT. This current paper applies that framework to the field of nephrology, focusing on chronic kidney disease. CKD, risk using my 12-year longitudinal dataset, from 2014 to 2025. CKD represents a complex outcome of both metabolic and vascular stresses. In my personal experience as a long-term type 2 diabetic, I developed multiple complications, including kidney problems, well before 2010. However, it was in 2010 when my physician officially confirmed that I had chronic kidney disease and recommended that I begin dialysis immediately. I have witnessed the gradual transition from metabolic dysfunction to renal damage. My goal in this study is to quantify the mechanical and metabolic stress energy contributing to CKD risk and to examine the underlying system stability through both viscoplastic energy modeling, VMT, and geometric topology, TDA. For this analysis, I selected the same 4 key input variables used in my recent CVD study to maintain consistency across organ systems: pulse pressure, pp, mean arterial pressure, MAP, fasting plasma glucose, FPG, visceral fat percentage, VF%. These 4 stressors jointly represent vascular stiffness, systemic perfusion, glycemic load, and adiposity, all critical determinants of renal health. As a 79-year-old male with controlled diabetes and normalized hemodynamics, my condition provides an opportunity to study CKD not as an acute failure, but as a long-term viscoplastic process, slow, cumulative, and partially reversible. Introduction. CKD develops as a gradual loss of renal filtration function, caused by the accumulation of vascular and metabolic stresses. Traditional clinical models often evaluate CKD using EGFR or creatinine levels, but these measurements represent downstream outcomes, rather than the underlying pathophysiological mechanisms. In addition, since laboratory tests for these biomarkers are usually performed only once every few months, I do not possess a sufficiently rich longitudinal dataset for them. In contrast, the VMT framework quantifies disease dynamics by linking strain, CKD risk or deformation, with multiple stressors, biophysical and metabolic inputs. This approach treats CKD as a viscoplastic deformation process of renal microvascular structures. This paper introduces a CKD risk versus 4 inputs model, based on 4 normalized variables: pp, hemodynamic pressure gradient, MAP, mean perfusion load, FPG, metabolic toxicity, and VF%, adiposity-related inflammation. Each variable contributes a fraction of the total viscoplastic energy that shapes renal health. My 12-year longitudinal CKD percent strain values, averaging 63.3%, were derived from composite indices that integrate kidney-related biomarkers, with associated metabolic indicators, FPG, BP, and VF%. These values reflect cumulative renal stress from 2014 through 2025. To quantify this relationship more precisely, I defined a CKD risk proxy as follows. This equation produces CKD risk levels ranging from 71.4% in 2014, gradually decreasing to about 60% by 2024. These results align well with my personal medical history in nephrology. I was first clinically diagnosed with CKD in 2010, which would correspond to an estimated 100% risk or higher at that time. The normalization anchors for my VMT energy analysis were established as pp is 40 mm of mercury, MAP is 80 mm of mercury, FPG is 110 mg per deciliter, VF% is 13%. These selected values are physiologically balanced for my senior age and serve as conservative, yet stable reference points for both VMT and TDA analyses. VMT energy analysis. The VMT model characterizes CKD as the interaction between a single output strain, CKD%, and 4 selected input stresses, pp, MAP, FPG, VF%. Each input curve in the strain stress space quantifies its viscoplastic contribution over time. The dataset from 2014-2025 demonstrates that all 4 stressors follow similar directional trends, except MAP, showing progressive stabilization after 2019. The computed viscoplastic energy contributions percentages are: pp is 24.1%, MAP is 23.8%, FPG is 25.8%, VF% is 26.3%. This nearly symmetrical VMT energy distribution indicates that mechanical and metabolic stress domains are evenly Balanced, approximately 47.9% from vascular blood pressure and 52.1% from weight and glucose. This finding suggests that chronic hyperglycemia and visceral adiposity remain equally important drivers of CKD progression. Matching the influence of vascular stabilization, PP and MAP. The cumulative VMT energy curve rises steadily from 0% in 2014 to 96% by 2020 and approaches 100% by 2025. The year of 2010 is the turning point. This saturation indicates that the renal viscoplastic system has reached an energy equilibrium, meaning additional stress no longer causes irreversible structural damage. In engineering terms, the kidney system has transitioned from an energy accumulating phase to a stabilized state, where internal stress is largely dissipated. This stabilization corresponds clinically to a plateau in my CKD proxy risk curve, consistent with my long-term lifestyle management and controlled hemodynamic and glycemic profiles. TDA geometric analysis, topological data analysis, TDA, geometric validation of VMT findings. Topological data analysis, TDA, provides an independent, mathematical validation of the VMT results through geometric interpretation. The same four normalized variables, PP, MAP, FPG, and VF%, were projected into a four-dimensional space, followed by dimensional reduction using principal component analysis, PCA. Principal component analysis, PCA, simplifies multidimensional data into orthogonal axes. PC1, PC2, and PC3, each representing a unique direction of variation. PC1 represents the dominant metabolic vascular trajectory, reflecting overall energy flow. PC2 reveals compensatory balance among the four stress domains. PC3 captures small, transient physiological or behavioral adjustments. The three TDA figures below illustrate these geometric findings. 1. TDA 2D diagram, PC1 PC2 projection, from 2014 to 2025. CKD risk geometry. The 2D scatter shows a large and dispersed pattern from 2014 to 2018, progressively contracting into a compact cluster by 2025. CKD % strain is plotted against stress levels of PP, N1, and MAP, N2. The downward trend indicates that as PP and MAP stresses decrease, more negative, CKD % strain also declines, reflecting physiological improvement. Around the neutral zone, from 0 to 1 range, CKD % stabilizes near 65%, from 2018 to 2019, marking the transition toward equilibrium. 2. TDA 3D diagram, PC1 PC2 PC3 projection, from 2014 to 2025. CKD risk evolution. The 3D data cloud demonstrates volumetric contraction, confirming that the multidimensional geometry of CKD risk became increasingly cohesive over time. It maps the three stressors, PP, MAP, and FPG, spatially, with CKD % as the color-coded output. Lower stress combinations, negative values, correspond to reduced CKD %, while higher or neutral stresses indicate elevated risk. The smooth gradient transition reveals geometric continuity, validating internal consistency between vascular, PP, MAP, and metabolic, FPG, domains. 3. Geometric contraction curve, TDA radius, from 2014 to 2025. The TDA radius, PC1 PC2 PC3, decreases sharply from 2014 to 2018, reaching a stable minimum around 2020, the turning point year. It then fluctuates slightly but remains compact through 2025, mirroring the VMT cumulative energy plateau. This contraction signifies reduced geometric entropy and enhanced systemic stability, indicating that the CKD system reached a long-term equilibrium phase. TDA conclusion. In my CKD topological landscape, the data points in the lower right corner of the 2D diagram and the upper right corner of the 3D diagram represent my most stable and healthy kidney states achieved after 2022. This geometric convergence demonstrates improved systemic coherence among the four stress domains. The CKD system, once chaotic and energy dissipative, has evolved into a low entropy, high stability topology by 2025, confirming both mathematical and physiological alignment between TDA geometry and VMT energy dynamics. Combined VMT plus TDA interpretation. The CKD risk model, using identical stress domains, as the CVD model, demonstrates parallel stabilization patterns across the 12-year period. Normalized anchors, PP is 40, MAP is 80, FPG is 110, VF% is 13. VMT energy ratios, PP plus MAP is 47.9%, vascular domain, FPG plus VF% is 52.1%, metabolic domain. TDA geometry, expansive topology in from 2014 to 2018 contracted into a compact manifold by 2025, reflecting systemic equilibrium. Together, the viscoplastic, energy-based, and topological, geometry-based, models produce consistent interpretations. Both reveal that the CKD system has achieved dynamic equilibrium. This balance implies that the kidneys, though exposed to long-term stress, have adapted to a stable operating point, where further deterioration is unlikely as long as metabolic and hemodynamic control are maintained. Discussion. The integration of VMT and TDA models demonstrates that CKD, like CVD, can be understood as a nonlinear, dynamic, and irreversible system governed by the accumulation and dissipation of internal stress energy. Unlike cancers, which result from mutated cells, both the heart and kidneys are partially reversible, organs that can recover function through sustained lifestyle improvements. VMT quantifies this behavior as cumulative energy, absorbed by renal and vascular structures. TDA, in contrast, visualizes the same process as geometric contraction, an intuitive representation of systemic stabilization. The close agreement between both models confirms that physiological adaptation follows predictable dynamic laws. The reduction of internal variance, or geometric volume, parallels the dissipation of stored energy. The relatively higher energy shares from FPG, 25.8% and VF 26.3% reaffirm the central role of metabolic stress in CKD development. These findings echo my earlier studies linking diabetes, obesity, and microvascular dysfunction to progressive renal decline. Meanwhile, slightly lower vascular energy shares, PP and MAP, indicate successful control of hemodynamic factors through lifestyle modification and recovery after stroke. In the context of aging, this balance between vascular and metabolic stress mirrors the body's ability to maintain renal function, despite irreversible microstructural damage, an adaptive viscoplastic equilibrium. Future comparative study, CVD versus CKD, high-risk patients. This CKD paper forms the foundation for a forthcoming comparative analysis of CVD and CKD models in high-risk patients. Both share overlapping mechanisms: microvascular stiffness, endothelial dysfunction, and glucose-driven oxidative stress, but differ in organ-specific strain responses. A future paper, my next paper number 1419, will quantitatively compare the VMT energy ratios and TDA contraction patterns of these two systems, offering a unified picture of how vascular and metabolic stresses manifest across cardiovascular and renal domains. Conclusion. This 12-year longitudinal study of CKD risk using VMT and TDA demonstrates that both physical and geometric frameworks converge on the same conclusion. Renal stress energy has stabilized, and systemic equilibrium has been achieved. The total VMT energy reached saturation by from 2020, 96%, to 2025, 100%, while the TDA topology contracted into a compact and stable structure, signifying that chronic kidney stress no longer accumulates. The close agreement between physics-based and geometry-based models reinforces the validity of the combination of viscoplastic medicine theory and topological data analysis as a unified analytical approach to chronic disease mechanisms. This finding is especially meaningful for elderly individuals with long-standing diabetes. Even after decades of metabolic strain, disciplined lifestyle management can lead to a stable, non-progressive CKD state. In other words, my journey from being recommended for kidney dialysis in 2010 to being free of CKD symptoms after 2020 has proven that the CKD condition is reversible. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights belong to the author. Gerald C.